everyone, happy Monday and welcome back to Instagram Live. I am joined today by Dr. Patel, who is one half of the Female Pain Docs account here on Instagram. They also have a podcast and they are two physicians who specialize in female pelvic health, and we are so excited to have them here. She's gonna get all So be thinking about your questions that you have about pelvic pain, and she is on her way in. Hello, Dr. Patel.
Hello, thank you so much for having us.
Thank you so much for being here. You put out such amazing content, and one of the things that I saw most recently is there's been so many different responses to a certain kicker's commencement speech, but I think that yours was my favorite because you talked about other diabolical lies, referring more to gaslighting that has happened in terms of women's health and gynecology. So do you want to start by talking about some of the common issues that you see in clinic that a lot of your pain patients have been either lied to or maybe not had it investigated enough to find the true driver?
Absolutely. So thank you for inviting us. I'm very happy to represent myself and the Female Pain Docs, which is Mira Kierbaker as well. So some of the work that we do is in pelvic pain and women's health in general. And some of the diabolical lies that I was referring to in that post was regarding our own health in terms of pain with sex is normal, pain with menstruation is normal, pain during or after pregnancy is normal. And this is a lot of the medical gaslighting that has been happening in the medical system for centuries in terms of accepting any sort of women's health concerns as just, well, that's what it is to be a woman, when we know that there's a lot more to it. And the system is unfortunately rigged in the sense that a lot of the research and understanding that we have of medical concept was based on the male body. And it wasn't until about 20 years ago that sex was even seen as a biological variable that can play a role in many conditions, including heart attacks, which affect women just as much as they affect men. But the symptoms of a heart attack is very different in women versus men. So that is what I was referring to in the diabolical lies that women are told in the healthcare system. And I appreciate your kind words on that post.
Absolutely. So in your medical practice, when a patient comes to you, what does it look like on that first meeting?
So that's a great question. So as a pain physician, Dr. Kierbaker and I are both anesthesiology trained and then further training in pain medicine, which is mostly interventional pain medicine focused on musculoskeletal problems such as back pain, neck pain. And then Dr. Kierbaker and I specifically chose to do more training workshops and self-teaching as well over the years and seeking out mentors in the field for pelvic pain. So a typical visit with a pain physician is very different than a typical visit with Dr. Kierpaker or I, which our clinical focus is in pelvic pain. So as pain physicians with that musculoskeletal understanding, we usually see patients that are referred from gynecology or urology or colorectal, all sorts of different specialties. But this is often after other things have been ruled out. So if they're being referred by gynecology, endometriosis or fibroids, all of those things have already been evaluated for. There can obviously still be pain on top of that we can help assess, but all of the major diagnosing in terms of, is this interstitial cystitis? Is this, prostatitis? All sorts of other sort of medical conditions for male and female pain have been ruled out, and the patient is being sent for a general pain workup in terms of what can we do to help the pain, or there's something going on, what more can we do to add an approach, a musculoskeletal approach. So my breakdown usually is, how can I help in terms of muscles, nerves, bone, or tissue? And I have a whole sort of algorithm that I explain to patients that what muscles can be involved based on what type of pain they're having, if it's in the urogenital or anogenital triangle, what nerves can be involved based on the anatomical distribution of, is this more along the pudendal nerve territory or posterior femoral cutaneous nerve or cluneal nerve territory? Because as we know, and you're a physical therapist, so you know this very well, muscles and nerves go hand in hand, as well as other types of bony conditions. So even if one thing is irritated, it can cause the domino effect, as we say, in other trajectories. So even if the nerves are irritated, the muscles can be irritated subsequently, or if the muscles are irritated, the nerves can be irritated as a result of that. So I go through the muscles, nerves, and bone breakdown, and then the treatment approach, which is a multifaceted approach, oftentimes lifestyle modifications, physical therapy. I am a big proponent of physical therapy. I advocate for physical therapy at every visit. Oftentimes, patients don't always have that buy-in, as we say. As soon as they hear the word internal, and I especially for my male patients, when I say things like, oh, this is going to involve rectal therapy, a lot of my male patients don't want to go. So that buy-in of telling them why physical therapy is important, why internal physical therapy is important, such as vaginal or rectal therapy, and advocating and creating that trust as a physician, advocating for that, I think, is a big part of ensuring that the patients go to physical therapy, stay committed, and do their homework. So anyways, that's lifestyle modifications, such as diet, nutrition, and then physical therapy. And then we go through the usual medications, injections, and all of that. But it's a very comprehensive visit. We talk about a lot. And even though they seem like, quick visits, we go through a lot of information.
And it sounds like a very holistic approach as well, because you've touched on the nutrition, you've touched on the musculoskeletal aspect, and then you are, as a physician, applying the medical aspect as well. And I love what you said about nerves and muscles, because a lot of patients have maybe received a diagnosis of pudendal neuralgia, and they're very hung up about this idea of this nerve. And what I like to remind them is nerves don't just get agitated and irritated on their own out of nowhere. that is not a thing. There's a general other driver to it, and so we want to be addressing both. And from a pelvic health physical therapy standpoint, we're very interested in how the muscles are coordinated and behaving, and how they may be impacting that nerve. And then you have this amazing skill set, and especially as an anesthesiologist, best knowledge of anatomy outside of radiology, maybe even the same, not to rank radiology ahead of you in your anatomy, not, but you're able to apply nerve blocks, or to do further investigation, whether you're trying to determine which nerves are involved, or to take the heat off for even just a little while. A lot of patients ask if they're a candidate for a pudendal nerve block. How do you determine who's a candidate for that?
That is an excellent question, and a lot of my patients have hesitation. So I tell them that, I work them through the block and I go through the steps. But in terms of who the candidates are, so there's two types of blocks, as we know. There's therapeutic and diagnostic. Therapeutic meaning that we can do the block in terms of injecting medication around the nerves, but we also put steroids around those nerves to really help decrease the inflammation. So that would be a therapeutic block. A diagnostic block would be just injecting that area around the nerve without any steroids. So patients where they might have multifactorial issues in terms of, yes, there's some nerve stuff going on and muscle stuff going on, but what is that primary issue in terms of the irritation? Is it mostly neuropathic or nerve related, or is it mostly myofascial or muscle related? That's when something like a diagnostic block might come into play, in terms of we do the block without steroid. We see how long and how well their pain is reduced. And then we can always just do the block again with steroid. In terms of the risks and benefits, that's what usually patients want to know, in terms of, well, what is the risk of getting this injection? Now, I do want to say, let's say something like a pudendal nerve block, which is one of the more common blocks that we do, or nerve blocks that we do for pelvic pain. There's three ways to do it. There's vaginal, rectal, and transgluteal, which is how we as pain physicians do it. So vaginal is usually done by gynecologists. Rectal is, it's more of a traditional, and I don't want to say historic, but it's more of a traditional block that was done by colorectal, by inserting a finger into the rectum, palpating the ischial spine, and then injecting in that direction. People don't routinely do transrectal pudendal nerve blocks anymore. And then the more common and popular approach now is the transgluteal, which is through the butt muscles, the gluteal muscles, which are some of the deeper, thicker muscles of the body, which is how we as pain physicians do it. We can do it under ultrasound guidance. We can do it under fluoro guidance, which is x-ray guidance. So I work patients through this process of, this is a transgluteal, ultrasound guided, or fluoroscopy guided injection. And the risk is pretty minimal in terms of infection, nerve damage, or bleeding. And that being said, I do tell patients to not sit in a body of water or submerge in water, such as a pool or jacuzzi, for about 3 days. So it's a pretty low risk injection. They can have some numbness in that area. They can have some numbness if there's numbness on the back of the leg. But again, these are very uncommon side effects. It's a fairly safe injection. So I tell patients, depending on how likely it is that they really do truly have pudendal nerve irritation, I will opt for a steroid block, which is that therapeutic block. If it's more of there's a lot of stuff going on, it could be cluneal, it could be posterior femoral cutaneous, it could be obturator, it could be pudendal. If there's multiple nerve territories that we're worried about, then I would opt for a diagnostic block, which is without any steroids. So that's how I really determine which patients should get which blocks, really based on anatomical distribution.
I love that. And do you commonly do these in clinic, or are you doing them more in like a cath lab environment?
So most of these can be done ultrasound guided in the office. So the way my office is set up, I do take them outside of the office to do the pudendal nerve under fluoroscopy. That's just how I do it, but I have offered them ultrasound guided for like sort of low risk non-steroid injections. They can be done in the office setting. I believe Dr. Kierpaker does do them in the office setting as well as the fluoroscopy setting as well. And the fluoroscopy setting would be basically, as you mentioned, like a cath lab setting, in the sense that it's a operating room, but it doesn't usually require anesthesia in terms of sedation. If a patient chooses to want sedation because of concerns with, tolerating the procedure, we absolutely can make that happen. But it is done in a procedural room rather than in a clinic.
Absolutely. And then if you have done the investigatory route and you did the non-medicated route and it worked, what is then your thinking and your paradigm after that?
So if they have great reduction in pain, and I do want to mention one thing. So successful blocks can be pain reduction. Absolutely, that's what we want. But we also want improvement in functionality or quality of life, right? So if patients say that, I have like 30% relief in pain, but I was able to tolerate sex without pain, I was able to stand for longer or sit for longer or move for longer, those are the types of factors that I really look for. Like, okay, tell me more about that. So you weren't able to sit on a hard surface, or you weren't able to tolerate completion of sexual intercourse with penetration and ejaculation and all of that, but now you were able to tolerate that. Tell me more about that in terms of quality of life, functionality, instead of just pain reduction, because pain reduction is what we want, absolutely. But oftentimes it's that quality of life and functionality that can happen without the pain reduction. So if they do have a successful block in that sense of pain reduction and or functionality or quality of life, then we can do it again with steroids, which is that therapeutic block that we were speaking about. There are other options that we can do under fluoroscopy, such as radio frequency ablation. And Dr. Kierpaker actually, I think, is in the process of writing this up. And we just had a study done on this in terms of success with pudendal nerve blocks. So we can do a radio frequency ablation, or we can also do things such as stimulation. So there are different types of stimulation in terms of peripheral nerve stimulation along the pudendal nerve, or spinal cord stimulation, or dorsal root ganglion stimulation. These are a bit more invasive, but again, they have excellent success with certain types of pelvic pain conditions.
Absolutely. And what does that look like? Is that the implanted, words are gone, the implantation at the sacrum?
So that's, again, a great question. So there's different types of stimulation. So peripheral nerve stimulation is the battery pack essentially would be in the gluteal muscles. If it's dorsal root ganglion or spinal cord stimulation, so that it's not into the gluteal muscle, it's a bit above it. So along that gluteal, basically along that hip bone where you were to put your hands and feel your hip bone, along that line, we would put in the battery implant. And again, these are pretty minimally invasive in the sense that they're not surgical open procedures into the abdomen or spine, like many of these lumbar decompression or sacral decompression surgeries are. They're done under sedation, and they are removable in the event that they don't work or there's any sort of concern about it. So they're a bit more invasive than pudendal nerve blocks, but they are absolutely a good option for patients who've had a lot of pelvic pain that has not responded to certain types of of therapies and have a component of central sensitization, which we know can play a big part in pelvic pain.
Absolutely. Can you explain what central sensitization is? I don't think we've talked about that a lot here.
So central sensitization is a concept, a pain concept, in the sense that the first time you feel the pain, the analogy I like to use, I'll kind of go based on the patient analogy that I use. Let's say the first time you hit your knee against the wall, you're like, ow, that hurts. But if you were to bang your knee against the wall 24/7 for 3, 4, 5 months, even touching the knee, as you can imagine, would be painful. So basically, central sensitization is a concept of the brain feeling pain louder than it usually does for somebody else, for example. So we know that central sensitization is a concept that we have seen in fibromyalgia now, that we know from fMRI studies, in the sense that the brain feels pain louder, even if it's quote unquote normal pain, like hitting your toe against the wall or hitting your knee against the wall or something like that. So central sensitization is essentially your brain dedicating more space and energy to that pain trigger than most other people without central sensitization. And in pelvic pain, we have seen this. Basically, regardless of any sort of pain, including pelvic pain, we've seen that the longer a patient is in pain, the more the brain dedicates brain space to that energy, or to that trigger. So we want to try to apply as many things early as we can. That concept of preemptive analgesia, and creating, breaking that cycle of inflammation, breaking that cycle of pain, to decrease the overall incidence of chronic pain and that central sensitization over time.
Absolutely. My two favorite book resources for patients are Why Pelvic Pain Hurts, which is by orthopedic physio, who explained it very similar to what you did. And then another is Painful Yarn, written by Laura Mosley, who's
Okay.
an Australian physio, and he describes the time where he was in Australia and he was out on a hike and he felt a brush along his leg, and he woke up in the hospital, and he had been bit by a very poisonous snake, as there are many. And that process left him very ill, and then he healed, he was fine. However, when he was hiking, he felt another brush, and he said his whole body experienced the worst pain he's ever had in his whole life.
Wow.
Dropped around, was certain he was about to die because he'd been bitten again, and it had been a blade of grass. But his brain had changed through that process that you just described, to perceive that blade of grass as a threat, and it heightened his pain experience, and it heightened his whole body experience to that. And him as a physio, he had done a lot of work and research in that area to help overcome that. But the way he tells it is way more funny than me. But it's a really great patient, well written, in terms of like they can relate to that experience. And I think that that's one of the most debilitating forms that we see, isn't it? Is the chronic pain, the people that are now having to learn how to dim that experience. And they're applying all these different modalities between the pelvic health, physical therapy, and seeing you.
Absolutely.
What else do you see clinically?
So I see all pelvic pain for all types of diagnoses, male and female pelvic pain. So oftentimes for when it's interesting, when I say that I treat pelvic pain, or I'm a pelvic pain physician, people assume that I treat just women pelvic pain patients. But often, I would say probably a quarter, if not a third, of my practice is male pelvic pain. So this would be things like interstitial cystitis, chronic prostatitis, rectal pain, levator ani syndrome, and whatnot. So pelvic pain is a very broad diagnosis. It's just a symptom, in my opinion, and not actually a diagnosis in the sense of why is that pelvic pain happening. We know a patient has pelvic pain, but what is the etiology in terms of what are we treating? Is it endometriosis with secondary pelvic floor dysfunction, as again you see as a pelvic floor therapist? Is it pudendal neuralgia with nerve component that both needs physical therapy as well as nerve blocks and neuropathic agents? So I see all types of pelvic pain, and oftentimes it's after they've been ruled out for all of the other stuff, as I say. So it's a very general term, but I really want to make sure that we've ruled out things like cancer. We've ruled out things like prostatitis that needs to be treated with antibiotics, or fibroids that need to be treated with surgery, or endometriosis that needs to be treated with medications. And then I come in and I play a role in terms of coordination of care, medications, injections, and whatnot that I can really help with. And one of the analogies I've recently started using with my patients is I often end up being a coach for my patients. They see me in between their other visits with their physical therapist, with their gynecologist or urologist or whatever it may be, and seeing me helps them stay on track in terms of, have you been doing physical therapy? How is your nutrition? How is your stress? Dr. Kierpaker and I are both trained in lifestyle medicine, which is a study within conventional medicine, but focuses on the concept of decreasing the burden of chronic disease, such as all sorts of other stuff like hypertension, diabetes, but also chronic pain. So we know that nutrition, exercise, sleep, positive psychology, all of these things can affect pain. So how can we as pain physicians be their coach, be their advocate, and coordinate care within a very convoluted healthcare system, which is a topic for another day, right? How can we really help the patient navigate the system, advocate for things like physical therapy, get them to the right physician, and really help them navigate their pain journey?
Have you seen an improvement along those lines of how convoluted it can be in this pain experience, and how many providers that they are often seeing? Have you seen an improvement since you were, say, in residency between then and now of getting faster referrals of your colleagues identifying that this patient has pain that needs to be truly addressed? Are you seeing them quicker?
Yes, in the sense that there aren't many of us that treat pelvic pain, as you know, especially pain physicians in the sense of anesthesiology or PM&R, or whatever background trained. There aren't many pain physicians that see pelvic pain. Thankfully, thanks to social media and the academic work that I do as well, thankfully people now know that, oh, this is something that I know somebody that can treat your type of pain. So I have been getting more referrals. Dr. Kierpaker as well. Both of us have been getting more referrals from in the system as well as outside of the system of, oh, we know somebody who does this, which in my personal book feels like a win in the sense of a very male dominated field such as pain medicine, which only 19% of pain physicians, if not a little less now, actually, I'm not sure. Not enough pain physicians are women. So if you have less than 20% that are women, and we're talking about very stigmatizing and personal issues, for now my male colleagues in and outside of my own healthcare system to recognize that, Dr. Patel, Dr. Kierpaker sees uh, pelvic pain patients, we're going to send them to you. I think that's a big win because it's being recognized as something that we can and do help with.
Absolutely. We will take that win and we will continue to build on it and continue to be diverting patients to you from whatever corner we can, because there's a massive need.
Absolutely.
Is there anything else that you would like people to know about pelvic pain and how you go about managing it?
I think this was a great session. We covered a lot. I always believe in empowering my patients and making them feel validated and heard and empowered with more information to navigate the healthcare system, which is a big part of, like I said, my own relationship with each patient, because I know that the system can be very difficult to navigate as a pain patient, let alone a woman patient or a pelvic pain patient. So I always say, keep asking questions, keep looking for more knowledge, the right physician, the right imaging, the internet in terms of Instagram and everything that you do and a lot of other people in pelvic pain space is just so vital. And I tell patients, I direct patients towards Instagram sometimes. And I say, there's so many people in the pelvic pain space on Instagram, especially from physical therapy. Um, and I think that that's a great place for patients to start and feel like, okay, I have to go to physical therapy. I have to do my homework. It's not just a one-time thing. It's a continuous lifestyle change. So I really advocate for patients to keep asking questions, be empowered in a healthcare system that can be very convoluted, and really, PT is your friend. And if I always joke in most of my lectures, I always advocate for PT, but I say that if I'm ever president, I would recommend pelvic PT for everybody, male, female, pre-pregnancy, post-pregnancy, all of it.
Dr. Patel for president, ladies. You got my vote. Massive difference when we're receiving referrals. There's a huge difference between a patient who is referred wholeheartedly from their provider saying, this will work, go, there will be results, versus try it, I don't know, or I don't know if it's going to help you, but here's like 6 visits, I don't know.
Yeah.
Massive difference. So thank you for advocating. It makes us all a stronger team together so that we can be better managing those teams. I always liken it to we're all in the canoe and we're helping to paddle the patient along to reach their goals of where
I love that analogy. I will definitely use that. And we're all on the same canoe.
all trying to just move forward.
Exactly.
Where can patients find you in your physical practice?
So I am located in New Jersey, in New Brunswick, New Jersey. I do accept televisits and I see patients in New Brunswick, in New Jersey in person. And then Dr. Kierpaker, who is the other half of the female pain doc, she is at NYU in Manhattan. And I believe she also does do televisits and she also accepts patients as well.
Absolutely. And we're hoping to have her on next time. We were trying to triangulate as to how many accounts can be live at the same time. And I do believe it's only 2, but I appreciate your time and your expertise so much. It makes such a tremendous impact on patients. And I think them understanding the other avenues that are available and recognizing that it can really take the edge off of some of those procedures. And we're all working together to fix the musculoskeletal drivers as well. So thank you so much for lending us your time and your expertise. And from people from this community, if you're not yet following them, go do so now. Their posts are amazing and so witty, and I just love it.
Thank you. Thank you so much for having me. And I really enjoyed this talk.
Thank you so much. Have a great rest of your day.
Bye.
Bye.